gas provides PEEP. The IMD breaths are by far and away secondary, usually not needed, though they can be an advantage if you have non-homogeneous lung disease. And please, 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 it's not a backup rate. It doesn't back up anything. So please don't call it that. It's confusing to the students and the residents to call it a backup rate. Backup rate gives the assumption that it somehow is going to function as a ventilator mode in case the baby's apneic or in case the jet doesn't work. That's not what it does at all. What it does is provide very few breaths to open atelectatic areas if needed. All right, so the next thing we're going to talk about is something that is, I think, here pretty much ignored, and we need to stop ignoring it because it's a very, very important part of what the jet ventilator does, and it can give you some real clues as to what's going on with your patient, and it's the servo pressure. Does anybody pay any attention to the servo pressure besides Jeff? And besides Mary? It's a feedback-controlled flow system which adjusts to maintain monitored pressure at the set value. It increases for bigger and more compliant spaces, and it decreases for smaller and less compliant spaces. So what does that mean? And these are all slides from the company, which hopefully will give you an idea. So you've got a certain amount of space, and your pressure, as you know, is going to be reached by giving a certain amount of flow. So in order to reach that pressure, you got to adjust that flow. The bigger the space, the more flow is required to reach the same pressure. Okay? So if you have a bigger space to fill, and you've decided on a certain amount of peak inspiratory pressure, then you're going to require a certain amount of flow to reach that. And if your space increases, the flow is going to go up. And if your space goes down, then the less flow is going to be required to reach the same pressure. So if you have a baby, you've got a certain servo number, and there's no magic number. It's going to depend on the baby. What's important is it going up or is it going down? Because when it's going up, it's going down, it's telling you if the space is changing. Now obviously there's going to be some fluctuation. But there shouldn't be a lot of fluctuation. There shouldn't be a big change in the servo pressure because it's going to tell you that something is going on. So you've got your target PIP. You've got something that you've decided your PIP is going to be, say, 20 or whatever. All right? Now, let's say your compliance improves. And this is important because let's say you're going to give surfactant. And sometimes we give surfactant on the jet. Well, let's say your baby's getting better. All right? So is your space going to get bigger or smaller? If your compliance is getting better, all right, you have less atelectasis, it's going to get bigger, okay? Now, the PIP that you've set is going to drop, all right, because you've got a certain amount of flow that is generating that certain amount of PIP. What the servo does, and any kind of servo, like servo control on a radiant warmer, is going to adjust the temperature based on what you've told it to do. If you've told it that you want the baby's skin temperature to be 36.5, and the baby's cold, it's going to increase the output of the radiant warmer for the temperature to go up. Well, this is the same thing. What it's going to do is increase the flow so that It's going to rise to push the PIP up to where you set it to be. All right? Now, let's say your compliance gets worse. Your baby gets sicker. Then what's going to happen? Exactly the opposite, right? You're not going to need as much PIP. It's going to go up because you've set it at a certain level in a certain flow, but now the compliance is less, so it's going to rise. So the servo is going to bring it back down so that it will be where you've set it to be. Okay? Does that make sense? So it just adjusts to keep your PIP where you want it to be, depending on what's going on with the patient. So we've already talked about one area where this can be really, really helpful, and that is post-surfactant. You really need to be watching your servo. It's one of the things on the jet that can be very, very helpful for you, because if it starts to go up, then you know that you've got an improving situation. Now, what if you have a pneumothorax? And this is another situation where you need to be watching your servo. Now, if it's not under tension, and many times we don't see this, but if it's not under tension, then the space is actually increasing. Your lung is the same size, but you've also got that space outside the lung that the jet's trying to fill with that pressure. Okay, so if it's not under tension, then your PIP is going to fall because you've got a bigger space, and it just isn't high enough to reach what you've set. So the servo will go up. But a more important thing is the situation of a tension pneumothorax. In a tension pneumothorax, if you've got a lot of tension in there, then the lung space is actually going to get much smaller. And under the circumstances of a tension pneumothorax, then the serval pressure will fall because you've got your actual lung space is much smaller. What if you have a right main stem intubation? What's going to happen is you're going to have a smaller space on the other side, so the PIP will tend to rise, and the serval will fall, bringing it back into the range that you want it to be. And if you correct it, then the space is going to go back up, the serval will fall again, and the PIP will fall, and then the serval will bring it back up to where you set it to be. So those are a lot of examples. The things that you will find most commonly are increased compliance after you give a dose of surfactant, for instance, increased air leak, and let's say leaks, either large leaks around your endotracheal tube or perhaps a hole in the circuit somewhere. So what's happening is your jet's trying to fill a larger space, all right? And so just think of it that way. It's trying to fill a larger space, and so your servo pressure has to go up. It has to go up because it's trying to bring your peak inspiratory pressure up to fill that larger space. So when it goes up, oftentimes it means your baby's improving, because the thing that we tend to see the most is that the compliance is improving. So in general, that's a good thing. When your servo goes down, it's more likely to be dangerous because it means your baby's getting worse. Either he has a worsened compliance, you have a tension pneumothorax, or, and this is the most common thing that happens, where I've mentioned to the nurses on several times, the baby may need to be suctioned, because you've got all those secretions in there. So what's happening? You've got a very small space that the jet's trying to fill. And so, particularly if you've got an obstruction, so the servo may go way down. So from a nursing care standpoint, if the servo falls, the first thing that you should think about is, gee, does my baby need to be sucked out? If that doesn't take care of it, and it's still considerably low, then a pneumothorax has to be something to think about. So I like this slide as kind of a summary slide. The servo pressure is automatically controlled driving pressure, controls it automatically, and it will change as the lung volume changes. And you will see that it does vary and go up and down, because remember, the lung is what? It's a very dynamic, changing organ, particularly early in the disease process. And so you will commonly see at least small fluctuations in servo pressure. So as the pressure goes up, the volume is increasing from some reason or other. And as the servo goes down, then the volume is decreasing for some reason or another. And you have to say, okay, what are the most common reasons why this may be, and try and figure it out. Okay? So we need to start paying some attention to this. In particular, after surfactant, in particular, if you think the baby may need to be suctioned, and in particular, if the baby's not doing well for some reason, and your pressure is changing, then it's a big clue to what may be happening. You may want to get an x-ray, you may want to get a blood gas, watch your TCOM. It may give you another hint at the same time. If you have a decreasing servo pressure and an increasing TCOM, you either have a pneumothorax or you have secretions, almost assuredly. So very, very important, and something we all need to start paying attention to more. Anything you guys want to say about servo pressure?
It's only in the jet, it's not in the oscillator.
It's only on the jet. Yeah, this is something unique to the jet. Sharia?
Because of this mechanism, the secondary pneumothorax compared to conventional pneumothorax is less. Because the data shows if the baby got the pneumothorax, the primary pneumothorax, if the baby switched to, the jet system, the high frequency system, the risk of secondary pneumothorax is less than baby being on the conventional pneumothorax because of this mechanism.
Well, no, not necessarily. I mean, the jet is very good at treating pneumothorax, but that doesn't mean that it absolutely avoids pneumothorax in all cases. I mean, any ventilator a baby who's sick can have a pneumothorax. And we hope that if we're paying attention to how we're managing the ventilator, that risk will be less. But let's say your baby develops a pneumothorax. This is a nice way to have a clue that maybe you do have a pneumothorax.
I have a question about that. Since in one case the servo goes up and in one case the servo goes down, it seems to me that it would be complicated to figure out with servo whether you can have pneumothorax.
I think the biggest thing that we're going to see is a pneumothorax under tension. If it's under tension and the lung space is quite small, then the servo pressure is going to go down. You're right, if you don't have it under tension, then it's going to go up because you're trying to fill this larger space where the lung is not yet scrunched way down again. So I would pay more attention. When the servo goes down, it's usually more dangerous than when the servo goes up, because you're either talking about a tension pneumothorax, a worsening compliance, or needing suctioning.
So the one that's the clue to the really bad pneumothorax
actually
is associated with the most common thing, which is suction.
Exactly, but it's just like anything else. I mean, if your suctioning doesn't immediately resolve the situation, then you need to figure out what else is going on and get an x-ray.
You know, when you talk about the decrease and increase in servo, are you referring to a percentage, or are you just referring, is there a clue? It can be 2.8 and then it goes down to 2.6. Is there a percentage that I need to worry about?
Yeah.
Is there data on that?
Unfortunately, there's not a percentage. You kind of get a feel for where it is on that particular patient, and I think it has automatic alarms too, which is a little bit of a problem.
What do they say? Above or below? What do you say?
10% probably.
You can also set your own alarms too.
Yeah, we can change the alarm setting on it too.
What do you set? Let's see, the baby's servo pressure is reading at 2. What do you set?
If
Alarm
it's
set.
reading at 2, it's probably, I'm trying to think of the think it goes like 1.8 or 1.7.
An absolute
I think
number
it's like,
above,
yeah,
and
something
not a
like that.
percentage.
It
So for us
does
to
like 2
watch-
above, it does like 2 above, 2 below, or something like that.
So 100%
Yeah.
above, 100% below.
Not 100%.
Yeah.
Okay.
But you can set it.
Yeah,
Right.
and sometimes if, you know, for babies who are breathing very actively, it will alarm more because it's going up and down a lot, so we might spread the, you know, might spread it out a little bit.
So we
So
are
it's not
basically
long
going
enough.
by the alarm set. We are not looking at an arbitrary value. If the alarm is set at 1.8,
But,
and
I
the
mean, it only
baby's
takes,
dropping below that,
but, I mean, if it drops like a 0.2, 0.3, and it kind of stays there,
yeah.
then that's a clue, because it will fluctuate,
Okay.
but, you know, that's a clue, like, you know, to suction.
Yeah, and that's a really good
Because
point.
it doesn't have to drop down like to 0.5, it'll be a smaller change than that.
Because of course, it's going to change with the flow rate and with the PIP that's set. So for every particular baby, it'll be slightly different. So it's more of a, as Jeff said, if it goes down and stays down, all right, then at least look at the baby and see what might be going on. And suctioning is often the most common thing. And if that doesn't take care of it, and your baby's also having, say, a rise in TCOM or increased work breathing, and that you have a low servo pressure, then it's an extra piece of information that can help you assess what's going on. It's not the only thing, it's just something we need to pay some attention to. Okay, so we talked last time about the inspiratory time, which is constant at 0.02 seconds for most things. There is some data now that there may be circumstances under which that may change. You may want to change that, but for us, I think we're not going to do that. That's experimental at this point. So the delivered tidal volume is essentially the same with each breath because your inspiratory time is essentially the same. And it's important to remember that changing the rate changes the IE ratio. It shortens or lengthens the expiratory time. It doesn't change the inspiratory time. The inspiratory time is the same. So if you have a rate of 240, which is 4 hertz, then the IE ratio is actually 1 to 12. And this is extremely advantageous for allowing the healing of air leak. And it's not, you cannot attain that on the oscillator. Remember that the only way you can get a 0.02 second I time on the oscillator is at 15 hertz. All right? So 15 hertz is going to give you a much shorter inspiratory time that is 4 hertz. So this is one of the big advantages for air leak, is the very short inspiratory time and the very long expiratory time. And one of the reasons that the flow of gas during jet ventilation is advantageous is that it is a very high velocity. And because it's a high velocity, the tendency is for it to shoot right past upper airway leaks. If you have pulmonary interstitial emphysema, you've got a tension, PIE, within the alveolar tissue and the lymphatics that is restricting alveolar expansion and also constricting the terminal airways. So you've got an increased resistance upstream from the site, all right? You've got an increased resistance up here. And remember what we said about during high frequency oscillation, when you have an increased resistance, you're going to want to use a slower rate, right? Just like you would with an asthmatic, you know, who's got constricted airways, all right, and then dilated airways down below. So if you've got a slower rate, if you've got a flow of gas that is a very high velocity, can go right past the area of air leak, then you're much more likely to allow that air leak to heal, all right, and to appropriately ventilate that child at the lower rate with the long expiratory time, all right? So this is theoretically the reason why the jet ventilator is better at air leak than the oscillator. The very fast inspiratory time, the long expiratory time that you can get at the very low rate attention to the fact that the long expiratory time is going to address the increased airway resistance and the way the gas flows, which tends to be very fast at a very high velocity and may go past the area where the air leak is.
Okay, I just have a question. The rate of 240, it's it's based on physiological principle, or is it studied? Is it an evidence-based?
It's based on a physiologic principle.
Is there any data that, I mean, is there anybody who used it and shown a better, is it published? Or it's just a single center thing, or?
It's
I'm just asking.
there's no randomized trial looking at treatment of air leak with a slow versus a fast rate, and there probably never will be. It's based entirely on the theory of why it ought to work better at this rate. And that's a problem now with a lot of ventilator settings. We'll never again see the large studies that cost millions of dollars, and that's why I think we have to think about the physiology. We have to think about what would work better, and then if it's not, doesn't seem to be better, then we can try to do studies, but it's just really going to be hard to do. But this makes sense if you think about it. When you think about what's happening, it makes a lot of sense that the longer the expiratory time, given the increased resistance of the airways, and the shorter the longer the expiratory time, the shorter the inspiratory time, with the high velocity gas, ought to allow the air leak to heal. So,
however, the cons for that is like atelectasis and lack of expansion because your right time is short. So in that scenario, would you use a conventional rate, or would you go open the pit? What is that would you do in the bedside?
if
Because
you have
often
air
we-
leak,
Yeah.
the worst thing you can do is put a conventional rate on, because you will be opening and closing the lung. So even though it sounds paradoxical, if you have air leak, the best thing you can do is go up on your PEEP if you need to open that lung. Because remember, then you're holding the lung open. All right? You're not putting on a rate which is opening that area of tearing. All right? The best thing you can do is go up on your PEEP sufficiently to open the lung. All right? Use the slowest rate you possibly can. Because remember, it's not the rate that really affects ventilation during high frequency. It's the tidal volume. Tidal volume squared times frequency. Same applies to the jet as to the oscillator. All right, so from a physiologic standpoint, that's the way to treat that situation.
One of the situations I see in this unit, which is a constant issue, is you have an air leak, you put them on low rate with no conventional breath rate, and you pass by for like 3 days, 4 days, and the X-ray changes obviously does not tell you what happens at the microscopic level in the lung. However, your hyperinflation has resolved. So in that situation, when would you revert the rate up, or when would you, what is the process for the weaning process for that baby?
Good question.
Because that happens frequently in this unit. We need to have some kind of a discussion on
Well, again, weaning has to be always on your mind. Now, with the jet, particularly when you have air leak, it takes a while for it to go away, and we're talking days sometimes, all right? So you have to kind of sit on your hands and accept borderline blood gases, watch your x-rays very carefully, and then, just like with the oscillator, if your air leak is resolved, watch that you're not getting overexpanded, because you want to bring then that PEEP down, that mean airway pressure down, all right, in order to keep the lung as normal as you can. Now, you don't have to go back up on your rate. It depends on your blood gases. Again, tidal volume is more important than rate. So if your air leak's gone and you feel like you might get a little bit of advantage from a little higher rate, you want to go to 300 or 360 because you can bring your PIP down, and that will decrease your tidal volume, then it's okay to do that. On the other hand, if your PIP, remember your PIP minus your PEEP is your tidal volume, and it's attenuated as it gets to the lungs. So it's not like a conventional ventilator where, remember the little graph, where whatever you give at the trachea, at the airway, is the same as down at the alveoli. It's going to be attenuated with the jet, just like with the oscillator. Nonetheless, if you're on a very high PIP and you'd like to get that down a little bit, make your tidal volume a little bit less, you can start going up on your rate if your air leak is gone. But I would recommend keeping your rate as low as you can as long as you have air leak, because physiologically that's your best chance of getting that to resolve.
Would you advocate for once you have an air leak, certainly waiting, which you said some going to take days to resolve, even in the face of x-rays that may be showing it resolved, that once you have an air leak to wait a couple of days before you go there, or like before you start to increase your rate?
It takes weeks sometimes.
Weeks. So
Well, if your air leak is gone,
well, what does gone mean? Like,
you don't see any air leak, you don't see any PIE, you don't see any pneumothorax. If it's gone, there's no reason to change your rate if the baby's doing fine. On the other hand, if you have a very high, if you've needed a very high PIP for some reason and you want to try and get that down, you can just start weaning it and don't worry about your rate unless you're having CO2 retention. The rate is really not a big deal, all right, because it doesn't affect your ventilation as much. All right, it will affect it some, but it doesn't really affect it a lot. All right, so if you want to go up, it's okay. I mean, there's nothing magic about it. The only important thing about the rate is try and keep it as low as you can if you still have active air leak. All right, and pretty much there are two rates that are used now: 420 when you have regular RDS and you're using a jet, and 240 if you have air leak. Now, some babies won't tolerate the 240. Some babies may be so sick that you can't get them there. But if you can try and then sit there, that's your best chance of getting the air leak to resolve, because of the very things we talked about: the long expiratory time, allowing the egress of air through those compressed airways, and the high velocity, short inspiratory time. So I like this picture because it kind of helps me see how an air leak can heal with that long expiratory time, that short inspiratory time. So again, ventilation is proportional to frequency times tidal volume squared. So it's your tidal volume that's most important. So if you get hung up on the rate, just remember not to. And because your inspiratory time is the same, your tidal volume is going to be pretty much the same with even when you change the rate on the jet. All right, so just remember that that's the most important thing, and your frequency is going to be secondary. So because the inspiratory time is constant, and due to the flow characteristics of the jet, the inspiratory spike that we showed, increasing the rate will decrease the CO2 to some extent, but increasing the PIP is much more effective because it will increase your tidal volume and be more effective. And don't worry too much about it because it is attenuated so much, just like on the oscillator. So a PIP of 30 is not being seen by the alveolus. The alveolus is seeing probably 3 or 4, not 30. So conventional breaths, the current thinking, and you'll hear this from the company representative also, is to try to avoid them whenever you can. If you're using them, the first thing that needs to cross your mind is, am I using sufficient PEEP? You should never put a conventional breath on a jet unless you're sure that your PEEP is sufficient. Again, back to the basics. Have you opened the lung? Have you opened the lung? If you have not opened the lung, you're using a conventional breath in the wrong way. They should be only used in cases of severe non-homogeneous lung disease with areas of significant atelectasis, as well as normal and overdistended lung. And most of the time, you don't need them. And we've had a couple of kids here that we've had to put them on. But most babies won't need them. Most babies will be on the jet because of air leak, in which case you don't want to use them ever, if you can avoid it. Most babies' atelectasis will resolve with just giving more PEEP to open the lung. Okay? So this is a big change. There's been a lot of changes that the Bunnell folks have gone through, and this is one of them. And sufficient PEEP and not using conventional breaths is now pretty much the way that people feel it should be. And if you think of the physiology, it makes perfect sense. The whole reason you're putting them on a high-frequency ventilator is to try and avoid tidal breathing. So you want to try and avoid that. So CMV, conventional mechanical ventilation, is contraindicated in the presence of air leaks, and unnecessary use of conventional mechanical ventilation during jet ventilation will cause lung injury. Remember, you cannot measure your tidal volume. All right, you don't know what you're doing. You can't measure your tidal volume with those breaths, so it's really hard to be sure you're not causing volume trauma. This is a series of slides that they use just to kind of go over the settings that you have to set. Some of them I like, some of them I don't. The PIP says common 20. Well, okay, that may be a place where you want to start, but please remember the baby's going to need whatever the baby needs. All right, so you could go higher than that, you could go considerably higher than that, or you may need less than that. You're going to raise your PIP, obviously, to lower your CO2. You're adjusting your tidal volume when you change the PIP, and you're going to lower to raise your CO2. Very, very important. Raise the PEEP if necessary. Raise the PEEP if necessary. Can't say it enough, to keep the mean airway pressure where it needs to be. And remember that you can't set the mean airway pressure with the jet. Very, very important. You have to bring it to where you want it to be, and the most important way to do that is by adjusting your PEEP. The rate, there's basically two rates that you're going to be using, 420 and 240. You're going to raise the rate to decrease the CO2. Small baby with RDS, people that use the jet for RDS, usually use a rate of around 420. Much higher than that, you don't get much effect. So again, the rate is one of the least important things. Kind of like with the oscillator. We kind of choose a hertz and we kind of sit there. And only under certain circumstances do we want to change that. We're going to lower the rate to lengthen the exhalation time, reduce inadvertent PEEP, increase the CO2, or if air leak is present. I time is always going to be 0.02. So remember, jet, I time 0.02, oscillator, 33% inspiratory time. Very, very, very important to remember the differences between those things. So we might want to raise the I time. I'm not even going to go there because I really don't want you to be doing that until it's studied better. We're just going to keep it at 0.02. All right, conventional rate, if you have to use it, and this is from the company. Notice that they're recommending 0 to 3. All right. So if we have to use it, we want to keep it as low as possible, preferably 0. When to raise, to reverse atelectasis. When to lower, every chance you get, especially if you have air leak or hemodynamics are compromised. So conventional PIP. All right, now this is another old wives' tale about jet ventilation. Remember that, just pretend you don't even have the jet there and think about what you're doing. All right, now there's this old thing about, well, my conventional PIP has to be 2 below my jet PIP. Well, think about that for a minute. What if your jet PIP is 35? Are you really going to set a conventional PIP of 33?
No.
What kind of tidal volume are you giving? Dr. D?
Absolutely not.
All right? Please don't do that. This is old wives' tale stuff. think about what you would, if you got to, if in your heart of heart you've got to put a conventional rate on this baby, think about what you would put as a reasonable conventional PIP. You know, maybe 20, maybe 18. Okay, enough to give what you think will be a normal tidal volume, because you don't know, because we can't measure it the way we can on conventional ventilation. All right? So please, 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 please keep that in
And
mind.
that pressure does get transmitted. That's the big difference.
You got it.
That's the big problem.
This guy has paid attention. Gold star for
Just,
Dr. D.
you know, you just have additional clearing of damage to the lungs.
Absolutely.
So you
Absolutely.
Keep it low or off.
Absolutely. So please, please, please put on some reasonable kind of peak inspiratory pressure if you have to put a conventional rate on. Now, this whole business of whether or not it interrupts the jet probably makes absolutely no difference whatsoever, even though it's a big company thing from back in the old days that you shouldn't let the jet be interrupted. Probably doesn't matter. It's been studied by Jane Pillow and her fellows, and it probably doesn't make any difference. I can show you the data on that if you're interested. But I don't really think that's going to be a big issue.
But you shouldn't really have it because it just means it's
Exactly.
too high.
It means it's too
You have
high.
to
You
lower
got
it.
it. You got it. You got it. Absolutely have it. Now, the conventional ventilation I time is commonly set at 0.4. There's nothing magic about that. If you have a small infant, I would recommend setting it to 0.3 because we all know from the talks we've had previously that 0.4 is pretty long for an inspiratory time of a normal child. All right. So there's nothing magic about that either. PEEP. PEEP, PEEP, PEEP. Whatever is needed. Whatever is needed, whatever is needed. Raise it to improve oxygenation, to find the optimal mean airway pressure, to get your SAT to be normal on the lowest possible FiO2. Lower it when air leaks are present unless you have atelectasis, as Shanti said. If you have atelectasis, even in the presence of air leak, even though it sounds paradoxical, you've got to open that lung. And then leave your conventional rate off, get your jet rate down, and give time for healing.
If we think the conventional rate is causing barotrauma or volume trauma because we can measure the tidal volume, why even then use it?
I agree. There are very, very few
Instead,
times.
go up on your PEEP if you have an oxygenation issue, or go up on your PEP because the delta P in your jet is PEEP minus your PEEP. So, you know, use that as your ventilatory mode. Like to reverse or decrease your CO2, you know, CO2.
Yeah, I think there are really rare
Yeah.
times. I mean, there are a couple of kids that I've seen with way over I think, Shuttle, you had one of them.
Yeah.
Big over distension in one area and very collapsed in the other area. And a very slow rate, I don't know what we used, 3 or something, actually did help that baby. So but it's rare, and you should only be doing it in that kind of circumstance. You should never be doing it for other reasons.
And then optimal PEEP, you're going to tell us about how they define that?
How they define it?
Yeah, the optimal PEEP, what they, you know, how they used to describe this is the PEEP where when you take the baby off the backup conventional rate, the O2 SAT stays the same.
Well, you know, I've heard that.
And so you found a PEEP where you're keeping the lungs open because if it's lower than that, the lungs are starting to collapse.
Yeah.
And then people would put the rate up, the backup rate, which
Right.
defeats the whole purpose. So it means you need more PEEP.
I think that's right. The other thing is the way we talked about it
Until
before.
you reach a good O2 sign.
Exactly. Or
Exactly. You want your PEEP where your
Yeah,
FiO2 is at a
intimate.
minimum, where your
Yeah.
FiO2 is at a minimum, just as we do finding the optimal PEEP, the optimal mean airway pressure on the oscillator. All right. So you have to play with it a I
I have a situation
you're
where
unconventional, you
often
can always
there is a
switch and
concern,
just
I think it's a myth in this unit where the chest x-ray is hyperinflated with PIU and your PEEP is already at 9 or 10 and your FiO2 starts going up, you're on a rate of 240 and there is a fear of increasing the PEEP with an increase in FiO2 because you're already hyperinflated and your ribs are touching the liver, like the groin, the lung is too much hyperinflated.
That's too high a peak, then. That peak has to come down.
So again, we also have to pay attention to the X-ray, and yes, your FiO2 going up, because maybe you're at the top of the curve, not at the bottom of the curve.
Well, your FiO2 is probably going up there because you're impeding venous return, more so than your,
But
you
that's
actually
really
have a lung that's not open.
But
I
you know
see
what,
that
you
all
need
the
to
time.
pay attention to your X-ray, your PEEP. This is a situation where, we keep saying, go to the PEEP. You also have to pay attention. You're already having 12 ribs, 11 ribs. Maybe going up on the PEEP is not a good thought here.
If your CO2 is the
Absolutely.
same, you might want to go down on both, your PIP and PEEP.
Absolutely. Absolutely.
Please
That's
don't
something
get the
that-
idea that everything means going up on the peak. You
Yeah,
also may
yeah.
have to go down on the peak.
Yes.
All right, and many times I've seen people going up on settings when what they've done is overexpanded the lung, and the baby's getting worse because of overexpansion, not because we need to go up on things. We need to go down on things.
Yes.
All right, so it really means paying attention to your X-ray and paying attention to your TCOM and your SATs. All right, and I couldn't say it better. Yeah, you have to be careful. FiO2 as needed. All right, so the 6 fundamentals of jet ventilation. All right, the delta P on the jet is your PIP minus your PEEP. All right, which is going to have the predominant effect on CO2. The rate is secondary. Okay, this again is directly from the company, so they're coming around to understanding the physiology much better.
You can see it on the chart.
FRC and mean airway pressure equals PaO2. This is what we've said from the very beginning. The most important thing is appropriate mean airway pressure. Increase the PEEP to avoid hyperventilation and hypoxemia. If increase in conventional rate increases oxygenation, then your PEEP's probably too low.
That's the point
Right?
there. That's it.
Your PEEP's probably too low. All right, your point here is not using a conventional ventilator. Your point is using a jet ventilator and getting the rate from your conventional ventilator off. Decrease conventional settings whenever possible, especially when air leaks are a concern. And decrease the FiO2 before your PEEP. And this is the same pretty much with all of the ventilation types we've discussed. If you can't get your FiO2 less than 40%, it's not time to wean your mean airway pressure yet. And that's pretty true across the board. Occasionally, if you have a very complicated kid like Tanzia, all bets are off. But this is pretty true. In most cases, you haven't opened the lung sufficiently until you can get your FiO2 below 0.4, and some people in Europe would say below 0.3 or even below 0.25. So wean your FiO2 first, pay attention to your X-ray, and then start weaning your mean airway pressure. So I think we've said that before. As oxygenation improves, get your CV breaths off, wean your FiO2 before your mean airway pressure. Then, as your ventilation improves, go down on your PIP. You can reduce your rate, and it also encourages spontaneous breathing, but again, that's secondary. Okay, old wives' tales. PEEP should be only 5 or 6. Those of you that have been around for a while remember this, and that's absolutely not true. And PEEPs double or triple that are not all that uncommon with the jet now, because we use what we need to use. So use whatever PEEP is needed. Wrong, and we were used to be taught this, always use a quote backup rate. It's not a backup rate, and we only use it for non-homogeneous lung disease. Wrong, the CV PIP must not interrupt the jet rate and should be set 2 to 3 centimeters below the jet PIP. No, use a CV PIP that will not contribute to volume trauma. Whether or not it interrupts the jet PIP is not important. Oh, that was a kid that we had here who we treated with the oscillator, meconium aspiration baby, up in the old unit. I think it was about 1.5 years ago. Big kid, term baby, and we just couldn't fix this kid on. I did everything I thought of with the oscillator, and he just didn't get it fixed. Anyway, we put him on the jet. He is overexpanded on this film, but he went from 100% to 50% within 24 hours and eventually weaned off. And we were considering him for ECMO. So this is just an example where the jet was very effective. It's very non-homogeneous disease, and it worked well. So if one thing is failing, try something else. I think that's it. We have a couple minutes left if you want to take the test. Pass these around. You can keep it.